liver disease. And we now shift to the next talk. Next talk will be presented by Professor Ibrahim, Mohammed Ibrahim. هيكلمنا على المانجمنت of thyroid disorders in cirrhosis.
بسم الله الرحمن الرحيم. الحمد لله. اولا اتقدم بالشكر للدكتور راشد حسن على الدعوه الكريمه للمؤتمر، كما اتقدم لسيادته بالشكر على اتاحته الفرصه لي ان انا اكون سبيكر النهارده في عنوان Management of Thyroid Disorders in Patients with Liver Cirrhosis. اولا Management of Hypothyroidism in Patients with Liver Cirrhosis. Decreased activity of type 1 deiodinase enzyme decreases the conversion of T4 to T3. Consequently, hypothyroidism and low T3 syndrome are frequently described in patients with liver cirrhosis. Disturbed conscious level in the setting of liver cirrhosis, which does not respond to antihepatic encephalopathy treatment, may be due to undiagnosed hypothyroidism, and even myxedema coma, which occurs due to profound hypothyroidism, may be misdiagnosed as hepatic coma in a cirrhotic patient. TSH results can vary by laboratory, with normal as low as 0.3 and as high as 5.5. Levels below 10 indicate subclinical hypothyroidism. Levels greater than 10 indicate overt hypothyroidism, which should be treated with a replacement therapy. Levothyroxine sodium LT4 is available in oral and parenteral preparations with a slow onset, long duration compared with Levo T3. Levo T3, which is leothionine, is also available in oral and parenteral preparations with rapid onset and short duration of action compared with Levo T4, and is used mainly IV in myxedema coma. The main medication used to treat hypothyroidism is levothyroxine sodium, a synthetic version of T4. The appropriate dose is given once daily, 1 hour before breakfast or at bedtime. Step-up dosing when initiating treatment is recommended to avoid cardiac overloading, with regular serum TSH testing until reaching the appropriate dose. While on maintenance dosing, if the TSH is not at the desired goal, the levothyroxine dose can be adjusted up or down. TSH values that are slightly out of range may be corrected by a single dose increment or decrement, such as increasing the dose from 100 to 112 microgram or decreasing the dose from 175 to 150 microgram. Selenium and zinc are cofactors needed for conversion of T4 to T3. Both of them are relatively deficient in liver cirrhosis, so supplementation is recommended. Treatment of myxedema coma with leothyronine, which is Levo T3, 25 microgram intravenous every 6 hours. There have been no reports of acute liver failure, chronic hepatitis, or vanishing bile duct syndrome attributed to drugs used for hypothyroidism. When given in high doses, thyroid hormone preparations can cause mild liver enzyme elevations. These elevations don't warrant treatment cessation nor dose modification, but only indicate the addition of liver support medications. Drugs used in liver cirrhosis interfering with levothyroxine include bile acid sequestrants, cholestyramine, sacrolfate, calcium carbonate, aluminum containing antacids, and BBIs have been shown to interfere with the absorption or metabolism of levothyroxine. ثانياً, management of hyperthyroidism in patients with liver cirrhosis. Basic lines of treatment of hyperthyroidism in general included: first line treatment, which is medication; second line treatment, which is operation versus radioactive iodine. Antithyroid medications are thionamides, which are methimazole, carbimazole, propyl thiouracil; non-radioactive iodines, Lugol's iodine, potassium iodide, and sodium iodide. Radioactive iodine: Symptomatic medications, non-hepatotoxic drugs are to be chosen. Propranolol, which is cardioprotective. Guanethidine eye drops, azathioprine, and teprotumumab used for treatment of orbitopathy or ophthalmopathy. Oxazepam, which is used as a sedative and tranquilizer. Subtotal thyroidectomy is to be performed according to precautions of anesthesia in liver cirrhotic patient and taking into consideration that the medical preparation for operation includes the use of propranolol and thionamides for 4 to 8 weeks before operation. Thionamides are stopped 10 days before operation, during which Lugol's iodine or potassium iodide can cover hyperthyroidism, and also taking into consideration the medical treatment of the possible post-operative thyroid crisis or thyroid storm, which includes IV fluid, oral or IV sodium or potassium iodide, oral or IV propranolol, and IV hydrocortisone hemisuccinate each every 6 hours. Hence about the general pharmacology of antithyroid drugs. Thionamides are oral drugs including methimazole or its prodrug carbimazole 5 mg tablet and propylthiouracil 50 mg tablet, 2 tablets 3 times daily for 4 to 8 weeks, then 1 tablet daily for the recommended duration of treatment. Delayed antithyroid effect of these drugs, the effect of them appears 1 to 3 weeks after their starting. Used as first-line treatment in preparation of subtotal thyroidectomy and post-radioactive iodine until its effect appears after 3 months. Side effects of thionamides include agranulocytosis and hepatotoxicity, which warrants stopping the drug and shifting to another line of treatment of hyperthyroidism. Allergy and increased size and vascularity of the thyroid gland and increased exophthalmos, which don't warrant stopping the drug. Propylthiouracil is more potent than methimazole carbimazole due to the added benefit of inhibiting the peripheral conversion of T4 to T3, so it may be used in thyroid storm. Also, it is preferred in the first trimester of pregnancy as it doesn't pass the maternal blood to the fetus. Iodides include Lugol's iodine, 5% iodine and 10% potassium iodide, 10 drops 3 times daily, or potassium iodide 60 mg tablet 3 times daily. They have rapid antithyroid effect which appears within 24 hours after starting the drug. Their antithyroid effect lasts for 10 to 15 days, followed by relapse of hyperthyroidism. Paradoxical effect of iodide therapy, used 7 to 10 days before subtotal thyroidectomy and used for post-operative thyroid crisis. IV sodium or potassium iodide. Radioactive iodine. Radioactive iodine, which leads to formation of radioactive T3 and T4, is stored in colloid and emits beta rays which destroy the gland. It is considered a substitute for subtotal thyroidectomy in case of failed response to or complicated medical treatment in patients unfit for operation because of their old age or because of their cardiac state, or unresponsive to operation. 80 to 150 millicuries per gram thyroid, single oral or IV dose with delayed antithyroid effect for up to 3 months, during which thionamides and or propranolol can be used. Hepatotoxicity of antithyroid medications. The first issue to know is liver function tested changes with hyperthyroidism. Deranged liver enzymes due to hyperthyroidism rather than intrinsic liver pathology are not uncommon. The reported prevalence of liver biochemical abnormalities in patients with untreated thyrotoxicosis varies widely, ranging from 15 to 75%. The suggested causes of liver dysfunction include direct hepatocyte injury, comorbid heart failure, associated autoimmune conditions, especially in the setting of Graves' disease, pre-existing liver disease, and hepatotoxicity of antithyroid medications. Although some patients may have a pattern of mild liver injury, about 1 to 2% can have fulminant hepatitis. Liver enzymes can return gradually to normal in as many as 77% to 83% of patients once thionamides are started. Hepatotoxicity of propylthiouracil, liver injury resulting in liver failure, liver transplantation, or death have been reported with propylthiouracil in adult and pediatric patients. Fatal cases of hepatocellular injury arising months after starting therapy have been described more in children. A more severe hepatotoxic profile in pediatrics. Because of its hepatotoxicity, FDA includes a black box warning which states that in patients newly diagnosed with hyperthyroidism and requiring drug therapy, propylthiouracil should be reserved for those who cannot tolerate methimazole carbimazole. So propylthiouracil is not to be used in cirrhotic patients. Hepatotoxicity of methimazole carbimazole, both are capable of causing dose-dependent idiosyncratic liver injury. The onset of hepatotoxicity is usually within 2 weeks to 12 weeks of starting the medication, and the pattern of enzyme elevation is typically cholestatic or mixed, although isolated hepatocellular patterns have been described. Risk factors include old age of the patient, high drug dose, liver cirrhosis, and alcohol intake, and history of cholestasis. Co-administration of glutathione and N-acetylcysteine reduces the risk of hepatotoxicity. Once hepatotoxicity is proved, the drug is to be stopped. Low-dose corticosteroid is to be added, and treatment of hyperthyroidism with subtotal thyroidectomy or radioactive iodine is shifted to. So, methimazole carbimazole are to be used in a childhood class A, cirrhotic patients with normal serum bilirubin with frequent monitoring of liver function tests. Hepatotoxicity of Lugol's iodine and iodides, these drugs are used pre and post subtotal thyroidectomy, and they are generally safe to the liver. Hepatotoxicity of radioactive iodine, there are case reports about radioactive iodine hepatotoxicity. Most of them stated that HBV infection is a significant risk factor for hepatotoxicity. Apart from these case reports, the hepatotoxic profile of radioactive iodine is generally better in comparison with methimazole carbimazole. From the previous data, a proposed approach to treat hyperthyroidism according to the childhood class of liver cirrhosis is as the following. Hyperthyroidism in a childhood class A liver cirrhotic patients is to be treated with methimazole carbimazole with frequent follow-up of liver function tests with immediate cessation of the drug once it proves to elevate serum bilirubin and or alkaline phosphatase. Hyperthyroidism in a childhood class A liver cirrhotic patients who proved to be susceptible to methimazole carbimazole hepatotoxicity are to be treated with either subtotal thyroidectomy or radioactive iodine. Hyperthyroidism in a childhood classes B and C liver cirrhotic patients is to be treated with either subtotal thyroidectomy or radioactive iodine. Take home messages. Determination of the liver state before starting the treatment of hypo or hyperthyroidism is mandatory with taking into consideration the liver function tested changes and the liver histologic changes attributed to both disorders. Hypothyroidism in liver cirrhotic patients is to be treated with levothyroxine, as in non-cirrhotic patients with no precautions. Carbimazole can be used in a childhood class A liver cirrhotic patients with more frequent follow-up of liver function tested changes attributed to its use. Thank you.